Value-based healthcare. Do we allow cherry picking or lemon dropping? Is the provocative statement that has been made by our two presenters. Or is this a way to implement evidence and evaluate the effect of implementation? In this session, our presenters will explain what the VBHC, or the Value-Based Healthcare Project on hip osteoarthritis is that they are running. They're running this across 7 teaching hospitals in the Netherlands. They've also implemented the best available evidence on post-operative restrictions. And the question is going to be, did it result in more dislocations or less? And how are you going to sell this information to insurance companies? And ultimately, how do we get best results? And as we think about this mindset that we're going to have. So we're going to learn lots about this, and no better person than Professor of Orthopedic Surgery, Rudolf Poolman, who is a consultant and a friend, and has been someone that I believe has done lots to champion evidence-based practice, and now as we move forward into value-based healthcare. He currently works as he has a special appointment in healthcare evaluation. He works at Leiden University Medical Center at OLVG Hospital in Amsterdam, the Netherlands. Welcome, Rudolf.
Thanks, Mo. Well, it's wonderful to be able to talk to such wonderful people as yourself and the group of people that joined us. And I've got a special guest today. That's my PhD student, Victor van der Graaf. He's actually a resident in orthopedic surgery. And he was at the moment of the lockdown started in the Netherlands, he would defend his PhD. So it was very unfortunate. It got just canceled on the day of the lockdown. So hopefully the 3rd of September, he will be able to defend his PhD. But he did a lot of great work together. And actually this was based on the skills I learned at McMaster at doing research in larger multi-center trials, all the insights I got from you, Mo, and your group, and still collaborating with you is we're spreading this this knowledge. And Victor is now part of this this group of bandits. So.
Well, Rudolf, if I jump in, I'll say then that I think this is going to be a good PhD defense trial for Victor. So we're all here to have a lot of fun and have a discussion. But this may be your trial defense. How's that, Victor?
That sounds perfect. Thank you so much, Rudolf. Thank you so much for your kind words. So good evening, everybody. Well, good evening here in Amsterdam, and maybe good morning or good afternoon, wherever you are. I'm very excited to kick off today's session, which is, well, as already said, all about value-based healthcare. After a brief introduction that I'll provide with some background about value-based healthcare, I will discuss a few topics, and hopefully after the sessions we can discuss more on them. First, I will talk about decremental cost effectiveness, and then Rudolf, you will continue with the cherry picking and lemon dropping, and also the growth mindset, how you can place those concepts into value-based healthcare. So the concept of value-based healthcare was introduced in 2006 by Michael Porter, who defined that value-based healthcare at its core is about maximizing the value for patients. So what actually happens in healthcare is that as the quality of our care increases, then the cost will also increase. So somewhere there's an optimum between this trade-off. And a natural thing to do, of course, is that you then start to focus on the cost. But if you do so, then the quality will, as a result, decrease. So what you should actually do is, instead of focusing on the cost, you should focus on the value or the quality. And by doing that, the cost will also decrease. So this concept actually was not new and finds its origin with William Edwards Deming, who's well known for the Japanese post-Second World War economic miracle, which he basically implemented and based on this very same concept. So to get to a value-based healthcare system, Professor Porter introduced the value agenda, and this has been designed all around the concept of integrated practice units, which you can see here at the top. So a second really important thing are the bundled payment systems, and unfortunately we haven't come this far yet on the national level in our country. But these bundled payments, and Rudolf, you will elaborate a bit more on this in the next talk. they could be actually a very powerful tool to break down the barriers that there currently are, at least in our country, between different departments, and therefore they can help to create these units. So for this talk, I'd like to elaborate a bit more on the aspect of the costs. And as I've told before, it's not primarily about the money. So the focus should be on the patient value instead. But for that, of course, we do need to be aware of the costs. So when we aim to measure the costs, we have to do this with a proper economic evaluation, which can then help us to enable a structural cost reduction. So these economic evaluations, they will ultimately help to guide our healthcare decisions, and they can best be visualized and explained by these cost effectiveness planes. So I'll explain them. When you compare two treatments and the new treatment is more expensive, well, obviously you will reject the new treatment. And similarly, if you look at the outcome in this example, QALYs, quality adjusted life years, you have a new treatment which has a better outcome, then, well, you tend to accept the treatment. So what if a treatment is more expensive, but also more effective? Well, then the decision, and you're at the right top part, then our decision to accept this new treatment is based on our willingness to pay. So if it's above, we reject it, and if it's below, we accept it. So how about the left bottom part? And that's what I'd like to focus on in this talk, in the rest of this talk. And I'll do this illustrated by an example from our own practice, in which we compared physical therapy to a meniscectomy in patients with degenerative meniscal tears. So we found that physical therapy was on average 1,800 euros cheaper than the surgery, but also 0.029 QALYs less effective than a meniscectomy, which was statistically significant. So if we look at the plot, we're somewhere in the left bottom quarter at the red mark, sorry. So the question here is, how much are we willing to sacrifice if we want to accept a treatment that is cheaper? So for this, I'd like to discuss the concept of decremental cost effectiveness, which is based on the willingness to pay. And the willingness to pay is actually country dependent. And in our country, to make it even more complex, it's also dependent on the disease severity. So it's anywhere between 10 to 80,000 euros. So how does it work? Because it may sound counterintuitive in the concept of value-based healthcare to accept a treatment that's less effective. But we've actually been quite comfortable with many decrementally cost-effective options outside of healthcare. So sacrificing our safety or comfort or both for economic gains. But more important, this can actually improve our quality of health because by doing so, we permit a more efficient reallocation of our resources. So by focusing on the cost, we actually can improve the quality as well. So let's go back to our cost effectiveness plane. How can we apply this willingness to pay if a new treatment ends up in the left bottom quarter? Because we know what we're willing to spend, but we actually don't quite know how much we want to save at the cost of our health. So the research by Nelson, which I showed earlier, they suggest that for the loss of each QALY to be acceptable, the potential cost saving needs to be at least double the amount of the willingness to pay. In other words, the utility of losses weigh heavier than the gains. So for instance, if the willingness to pay threshold is for a specific disease in the blue line, 10,000 per QALY gained, then the cost saving should be at least 20,000 per QALY lost. And of course, similar for if you have a threshold of 80,000. So how can we interpret our results into this? Well, if we found a cost saving of nearly 62,000 per QALY lost, so this would match a cost effectiveness threshold of approximately 31,000 per QALY gained. And for that to accept this treatment, this depends in our country on the disease severity, but you can compare this to the willingness to pay threshold. So value-based healthcare will lead to a higher quality of our healthcare and simultaneously reduces the costs. And I'd like to conclude that decremental cost effectiveness offer an extra opportunity to improve the efficiency of our health resource allocation. So the main question remains, do we allow decremental cost effectiveness in the concept of value-based healthcare? and maybe more ethical, which we may can discuss on, how much health are we willing to sacrifice at the cost of economic gain? Thank you so much.
Thank you, Victor. So this is a great talk. And Mo, do we do a question and answers now, or do you want to?
No. I would just proceed with yours, and then we'll go to a full discussion period.
Good. So I will share my screen. So I will chat with you a bit more about value-based healthcare concept we're running right now in the hospitals that's called Santeon hospitals. And actually it was also published in a paper by the BCG group, Boston Consultancy Group. They helped us setting this up at the beginning. So we learned a lot from those guys, and also from Martin Parker. These are the hospitals. Netherlands is a very small country. It's about the size of Los Angeles and about the same number of inhabitants. So these hospitals, they are actually quite nearby. The farthest distance, I think, is about 300 kilometers in between these hospitals. You can see here what the revenues of these hospitals are, and it's about 11% of the total hospital care in the Netherlands, with 2,000 physicians and almost 30,000 employees. A lot of patients, a lot of outpatient visits, so we're a pretty big group, and this is useful to get bigger numbers quickly. So the ambitions of this hospital group is to actively involve patients in their treatment choices, and also make sure that the care of the quality of the care is transparent. They like to have the professionals work closely together, and also to set up innovative platforms and do a lot of research, and also try to make the care affordable and accessible. So these are the 5 ambitions of these hospitals. As Victor explained briefly, value is the outcome that matter to patients, and it's divided by the cost. That's based on Porter's ideas. And what we did actually is we look at survival. We're talking about hip arthroplasty right now. Complications, readmission rates, patient-reported outcomes, and also the patient-reported experiences. At the cost, these are defined by the length of stay and the consultations at the outpatient clinic, the need for medication, how many x-rays and other tests are done, and also we're looking at operating theater time. So that builds the quality and actually the value based on the value-based healthcare principle. So what we're doing is we are running a standardized improvement cycle across our 7 hospitals. So first we create a multidisciplinary team in each hospital. Then we have a standardized scorecard, and on the scorecard there are patients, the things I just showed you, and then there's every 6 months there's a cycle, so 2 cycles per year, and this is about patient groups, so not really about a procedure. So we're talking about hip osteoarthritis here, and we also started knee osteoarthritis, and also for hip fractures we started these setups with the continuous improvement cycles. So first we start collecting data to see if there's inter-hospital variation. And if we see these variations, we analyze these, and we'll discuss this in these groups, and then we propose improvements, and then we'll try to implement these improvements, and then when the next cycle comes, we'll see if it's actually working. It's important to say that in these multidisciplinary teams that are composed of nurses, patients, and it's very important that there's also patients involved to see what is actually important to the patients, and orthopedic surgeons. And so actually the whole scala of people that are working on these patient groups, on patients with osteoarthritis in the hospital, are involved. And the next level is we're trying to also get involved the general practitioners to really get all the osteoarthritis patients. So you can see here there's 13 disorders in these 7 hospitals that are looked at right now, and still expanding. So as I said, we're defining a group of patients. In this case, we are looking at the osteoarthritis of the hip. Then we discuss the treatment options. For hip osteoarthritis, this is a non-operative treatment comprised of physiotherapy or pain medication, and then also, of course, total hip replacement. And we look at a scorecard based on the outcomes, cost indicators, and process indicators. And we try to keep it simple and practical, and we like to have it aligned with the international standards, and we use only existing data. So we don't start collecting new data or adding questionnaires or don't overcomplicate things, to keep it simple and just feasible. So this is one of our patients, actually, I said it in Dutch, and she said we should actually run only improvement projects in healthcare with patient involved. And she was one of the patients that were part of our team for the hip osteoarthritis project to improve things. And so she was in this continuous improvement cycle involved. And then we were discussing dislocations, and it was found actually that you can see the dislocation rate following hip arthroplasty, and it wasn't too bad. And she said, why should we have all these restrictions post-operatively if these dislocation rates are actually pretty good? So over 5 cycles, it was only actually around 1%. So this was a pretty good dislocation rate for following hip arthroplasty. So, and then we went to look into the literature and found the best evidence. And we found this systematic review that was actually also from the Netherlands to look at what is this restriction following and these precautions, like you can only sleep on your back and you have to walk with canes and you cannot lay on your side for 6 weeks. So what is this actually reducing the dislocation rate, or is this also decreasing the quality of life for patients? Because she thought it was really annoying to lay on her back for 6 weeks. So, well, Siri is also interested. Oh, stop. Siri is always trying to listen. So what the systematic review found is that there's no increased risk of dislocation if there's more liberal restrictions, so stop with the restrictions. And also the patients are more satisfied and they will resume their activities and work earlier if they are managed with a more liberal protocol. So that's what we thought. Well, we collected these data. We could see there's pretty good results for the dislocation. So we thought, well, there's new evidence. Let's try to find if this is changing our practice if we implement this. So we started based on the thought of a patient, looking into, so this is actually the evidence-based cycle. You start with the patient, and you end with the patient, and you try to implement the evidence into practice. So as you can see here, the cycle we went through in 2017 to the beginning of 2019. And this was the effect of less restrictions. You can see that 6 months later, the dislocation rate didn't went up. So when we introduced this more liberal approach, we had similar dislocation rates. And there's always a variability, but this is normal variation. And we thought we shouldn't worry about this. So, well, this brings me to a next level maybe of implementing evidence and creating a learning health system. And then I came along this paper that was published last year in the New England Journal of Medicine, because now we started this new practice of less restrictions for all the 7 hospitals, and we did it before and after analysis, but we didn't do a real experiment. So maybe this would be the next level, and I want to discuss this with you, if this would be even more feasible, and to see if the results will be more reliable if we can follow this idea based on Horowitz's paper. So actually what we saw, that there can be circular trends, selection biases, regression to the mean, loss to follow-up. There's a lack of control group. Maybe the implementation wasn't perfect in all hospitals. Maybe some surgeons said, well, you better be careful and sleep on your back for a while. And so we don't really know the true implementation of, or de-implementation of these strict rules. So this is maybe also happening with our value-based healthcare projects in these 7 hospitals. So maybe this kind of program will be successful candidates for randomized quality improvement projects if there's a high volume of events and short-term outcome, and events that are already routinely captured. And this is actually what we're doing in our value-based healthcare projects. This is high volume. We are 7 high volume hospitals, and the outcomes can be pretty short-term, like dislocation of the hip. So these things could be successful. So there are some ethical considerations. So there's a gray line between research or quality improvement projects. So this is interesting to look at. When will something be a quality improvement project, and when will it be research? That's an open question we can chat about later. So maybe we should go to a hybrid effectiveness implementation design, and we can do a stepped wedged cluster randomization, and we run these improvement cycles and try to implement or de-implement things like these precautions and see what the outcomes is. And then it will be the next level, not just starting it in all the hospitals, but see it if you start in some hospitals and at some hospitals to see if it's actually working, and you can do it in a randomized design. So it will be a true experiment. And based on experiments, we can have causal inferences. And based on observations, it's hard to make these causal inferences. So maybe we should start doing this in our value-based healthcare projects to see if we can really implement or de-implement things, and if it's based on our implementation or de-implementation, or it's just regression to the mean. So because I think collecting without experimenting is creating data graveyards. This is what we're trying to do quite a lot. We're doing a lot of data collections without experiments, and maybe without experiments, this is give not too much information. So maybe these rapid cycle randomized quality improvement projects may be potentially extremely effective. They don't cost too much because actually we're doing it. And it can be part of a learning healthcare system. And maybe it achieves the triple aim of providing better health and better healthcare at lower cost. So this fits into the value-based healthcare concept. So maybe this also is the future of healthcare evaluation, because actually, if you look at the different treatments we're evaluating in the large trials we're running, actually there's an uncontrolled trial going on, an uncontrolled experiment going on in the world with all the different treatment options you can get for all, without a proper comparison randomized. So it's easy to focus on outcome, but outcome is out of your control, or is it? Maybe it's not so much out of your control. And this is the hazard of value-based healthcare if you only look at outcome. So what if happens if you get paid for outcome? And here comes the hazard, because I think value-based healthcare works really well for quality improvement and implementing stuff and implementing evidence, but not so much if you get paid for outcome, because then we may get cherry picking or lemon dropping. So cherry picking is choosing the patients that are likely to do well, to have a good result. And lemon dropping are the more sick patients with a lot of comorbidity and obesity and maybe a lower socioeconomic background. And they tend to have more complications and a worse outcome. So if we get paid for outcome, we might make unethical choices to select the fit patients, and the patients that need the treatment most, they get dropped, the lemons get dropped. So this is one thing we should think about when implementing value-based healthcare at the current model. So bundling care hurts the patients most who need it most. This was an essay in Forbes, and you can see what equality and inequity means. So I think there was a very clear illustration that some patients just need a bit more help than others to get better. And so they will cost more, and we need to fit this into these programs. So the New York Times also discussed this. Is it getting harder to care for poor patients? We really should think about it, because the poorer patients often need the care most. So focusing on outcomes, in my opinion, results in cherry picking and lemon dropping. So we need to think about something else. And here comes the growth mindset. So if we get paid for the growth mindset instead of the outcome, the growth mindset was developed by Carol Dweck, and was actually based on school children's ability to do math. So a lot of kids, they say, I can't do math. And Carol Dweck found that if you add the word you can't do math yet, makes them able to try to do their best and try to get better at their math. So I think we can set this mindset also in healthcare. If we are trying to improve our healthcare and get paid for the improvement projects instead of for the outcome, this may help the patients better than just paying for outcome. So people with the two mindsets, if you look at the challenges, people with a fixed mindset, they avoid challenges. People with a growth mindset, they embrace challenges. And obstacles are easily given up by people with a fixed mindset. And people with a growth mindset, actually that it's teachable, so people can learn the growth mindset. They persist, and also they keep going also when there are setbacks. Effort is... Sorry, oh. So this is really annoying. So just switch it off. You can see that effort is the path to mastery. So you need to train, and it takes hard work to get better. Also, people with a growth mindset, they know how to deal with criticism. They try to learn from criticism, and people with a fixed mindset, they ignore it. And if we try to get this into healthcare and to learn from our mistakes and to get better from mistakes, and or if we have poor outcome, for instance, in these value-based healthcare cycles we're running, we try to learn from these poor outcomes and to get better. So if we have a fixed mindset and we only get paid for the good results, this will not be the best thing to do. So we keep also getting better, and also we can celebrate the success of others. And as a result, we'll be much quicker improving, much faster improving than if we have a fixed mindset. So I'm trying to find a way to mix this or fix this into value-based healthcare projects, and try to look at the improvement cycles as a goal and not at the outcome as a goal. So we need to focus on the learning process, not on the outcome. And maybe these rapid randomized experiments, they fit into this growth mindset. And actually I saw one of most posts recently about goal setting. And I think we can learn a lot about goal setting also in healthcare. And goal setting can be also seen as a new concept of improving the care for patients. But also goal setting is, the goal setting theory is interesting to look at. So are we looking at the outcome goal or improving, or is it the process of the improvement and not the goal at itself, so the outcome at itself? So thinking about motivational sciences is a new way of thinking about value-based healthcare that might improve the care for patients much more than just focusing on the outcome, which may result in lemon dropping and cherry picking. So this is a learning process, and how should we try to use this instead of the easy outcome measures? And also, how can you convince insurance companies how to pay for this? Next level maybe is triple aim. Value-based healthcare is pretty much focused on a disease, and triple aim is focused on a person. So actually on prevention has nothing to do with value-based healthcare. It's really much about intervention medicine and not so much about prevention medicine. And maybe we should prevent people getting overweight and prevent people from being sedative and not working out, and getting more osteoarthritis by sitting down than by working out. The improvement method of value-based healthcare is quite linear, otherwise triple aim is much more circular. The market mechanism is competition in value-based healthcare, and there lies the hazard of cherry picking and lemon dropping. And collaboration might improve the care much more than these competitions. So we have a competition-based healthcare system. At least it was tried to set up in the Netherlands, but now people are shifting more to this collaboration system. So that's the triple aim idea. And maybe we should go to the quadruple aim, because if we look at the folks who provide the care, especially in this time of COVID, we see that if you care for the people that care for patients, that shouldn't be ignored. So this is the quadruple aim. From triple aim to quadruple aim, we should also involve the caregivers. That may be much more important that we think about up to date. So we can discuss and chat about this. Do you concur with me that the current concept of value-based healthcare is resulting in cherry picking, or can it be a tool to implement evidence? And what should be next?